We have Fred Gottlieb. I've had the privilege of working with Fred for many years as his relationship with our Division of Public Health and in his teaching of our course on international health issues. Fred, among other things, has been a regional medical officer for the Peace Corps. Very pleased to have Dr. Edgar Rodas here. As many of you who are here this morning were acquainted with him and the work he's doing in Ecuador and other places. And then Theodore Espiritu, who is an industrial designer. So I think a very interesting panel that integrates both a medical and public health approach to extreme affordability in the context of, among other approaches, surgical care, as well as somebody who's in the field of trying to create those tools and devices that will help us as we move to a more affordable and accessible future of appropriate care. I'm going to take moderator license and ask the first question, and then if you have questions for our panelists, we'll try and take 2 or 3 questions after their responses to this first question so that we can be efficient with our time. The first question I have is, in the U.S., we've developed a health system that has increasingly turned to high-cost, high-tech, and highly specialized approaches to care at the expense of access and affordability for many segments of the population. Further, the resources required for this model are not conducive to global replication, especially in developing countries. What recommendations do you have for jointly making appropriate surgical care available for the entire U.S. population as well as the world?
Well, I think that unfortunately, this model that you have described is being copied in the developing world. So everybody thinks that the best medicine is going to be with more sophistication, with more expensive equipment, and better hospitals. That's all. I think that something that applies everywhere is the attention to primary care, like the World Health Organization recommends. So primary care should be the main concern because this avoids and prevents lots of the diseases that then have to be treated at the hospitals. And second, for surgical care, I have to take my point of view, and I think that mobility of surgical services can be organized everywhere in the world and would be a big advantage and will solve many problems that otherwise are unsolvable.
Thank you.
So I'm going to frame my response primarily based on product development and the process associated with developing devices, in particular medical devices. One thing to consider is the primary product platform and then extending from that product platform. What I mean by that is developing a system that it can adapt to various environments. So the third world application, that is an environment that has specific use requirements and specific technical requirements. But if you pare that down, you position the technology for first world integration, you can create a system that would package for that situation that would decrease cost. So you're leveraging technologies from third world applications and you're starting to position that and consider a third world application position with integrating and capturing technologies and leveraging existing technologies.
I'm an internist. I don't deal so much with the surgery issue. One of the things I would have to agree with is the idea is you have to make this a public health issue. In areas we've worked in, very remote areas where there are no roads, particularly in the remote Himalayas, we partnered with a local medical school, and in exchange for us coming and teaching, they agreed to do mobile surgical units, which was actually 2 to 3 days hiking. And they would just ask us to do the triage to have appropriate surgical conditions. But of course, none of this is emergent. What seemed to be most successful for everything we did was better water supplies and decreasing issues of malaria.
Okay, let me open it up to the audience, and if we could get just 2 or 3 questions, I think we'll limit it probably to 3. if there are questions, and we'll just take all of the questions first and then allow the panelists to respond to which of those they feel most able to do so. Any questions? I have others, so I'm happy to, I have all sorts of questions I'd like to ask this panel, so I'm happy to take advantage of this time. We've got one over here and then, one here. Okay, we'll take this one first and then we'll go over here.
One of the challenges we've had trying to develop products that are low cost and high quality for each of the core areas, many times people think it's just low cost. But what we're looking for is high quality, low cost products, and yet it's very difficult to find the market or the people who are willing to try to develop that. Is there really a market for that, and how do we build that market and build the ability to correct some of these problems with these low-cost products?
Great, thanks, Ray. The question over here?
Generally speaking, preventative medicine is much more cost-effective than reactive medicine. How do we go about, especially in the United States, changing the cultural perspective on preventative medicine and making it a more popular thing to do for the population at large?
Great. So how do we, I think we lost you on the last part of that, but how do we change the culture to make it, as in your words, more popular for preventive care rather than reactive care? Does that capture that effectively? Great. And then one more, if there's another one. I will throw a third one in, and then we'll turn to the panelists to respond to any of those. As efforts are made to make surgical care an extremely affordable resource, and this is the panel on extreme affordability, what disciplines are not sufficiently engaged at this point to optimize this process? So with those three questions, and the three questions again, the last one, what disciplines need to be at the table? The previous question, how do we make preventive versus reactive care more culturally acceptable and even preferred? And then finally, how do we develop a market that is willing to produce high quality, low cost approaches to care? And so I'll turn it to our panelists. Edgar, we'll start with you.
I would want to address the question about preventative medicine. I don't know about the United States too much, but I think that one strategy that will work anywhere is to implement family medicine. I think that everybody in the country, every family should have their own doctor. In my country, I have studied the problem. It's not difficult because we have 13 million people, and with 13,000 doctors, family doctors, you can cover the whole population. You divide in sectors geographically defined and with the amount of people defined also, and have a doctor in charge to be in charge of all immunization problems, education, family and child care, maternal care, etc. So if you can implement the system, the doctors will take care to educate to the people and prevent most of the diseases, to change this culture that always is trying to look for specialists directly, and many times people make the wrong choice.
So I'm going to address Ray's question. So one of the difficulties with developing products for third-world applications is certainly the cost associated, and you want to maintain the functional aspects and requirements of the device itself. One thing to look at from an industrial designer standpoint is certainly understand the user scenario and the requirements from the various stakeholders. So you have the end user, you have various end users, you have the surgeon, you have the patient, you have the manufacturer of the device itself, and they're looking at the device from their standpoint and their interest and what is going to qualify the device as a success to them. One thing you can do is leverage the technologies in terms of the platforms, as I mentioned earlier, as well as integrating existing components and systems into your primary systems and subsystems. That way it's a modular system, so if something fails, it can be easily repaired and you're not dependent on huge infrastructure to support the device. With that, I think ergonomics and human factors are a big consideration as well. Human factors in regards to creating a positive experience for the various stakeholders and understanding the end user and being empathetic to the end user and understanding what qualifies as a good experience to them and what qualifies as a negative experience to them, and really associating and understanding how to integrate that device within that infrastructure so it is a positive experience.
And I want to go back to the preventive care question. I think the cost of care in this country isn't affordable. And one of the ways to get increased access to care would at least to be consider universal single-payer care. Certainly not popular in this country politically. Yet it seems to work overseas. Even very poor countries like Bhutan, they have universal immunization. They can do HPV vaccines and prevent cervical cancer, and it's not acceptable here yet. Many countries have decided that public health, which is not going to benefit anyone but the public, it's not quite it's not a money-making enterprise, is a more effective way to go. In the country, we should do that. If you have migrant farm workers who have no access to care and have TB, it is incredibly cost-effective to get them into the health department and treat them for TB rather than allow that to get into the community. We should be able to do things like that because it's exceedingly cost-effective, much less compassionate and humane.
Great. Thank you for those responses. Since nobody answered my question, I'll ask the final question for the panelists. Clayton Christensen, who's been a presenter here in previous conferences on extreme affordability or on global surgery, talks about this idea of disruptive innovation. And if you look out the windows, you can see the community where Clayton grew up, just beyond Salt Lake City proper. He describes a disruptive innovation as a process by which a product or service takes root initially in simple applications at the bottom of a market and then relentlessly moves up market, eventually displacing established competitors. I'm going to ask you to look into the future for us and tell us what you think over the next 10 years, what sort of disruptive innovations you anticipate in the field of surgical care. Fred, can we start with you this time? We'll start at the far end of the table. You look too comfortable there, as if you had a moment to think.
I don't know. I think one of the things that I've found overseas again is that people are going from simple surgical procedures to laparoscopic procedures in places like India, Nepal, and Thailand. It's being demanded by the public, but it still may not be as affordable yet. I'd like to see the things that I'm hearing today become accessible for that population.
Great, thank you. Theodore?
I would say point-of-care diagnostic devices. And the reason I say that is there's an opportunity to leverage existing technologies such as smartphones and smart pads and integrate those technologies so they can be taken out into the field. And of course, a diagnosis can be made, and then of course, preferably a remedy, a solution to that. And I think that is an affordable direction to pursue now because you're not having to reinvent the wheel, you're not having to investigate and spend resources in development time when you get to, or you're able to leverage existing technologies and use them for those applications.
And that's actually being developed now for some water quality projects. And that would be remarkable in underdeveloped countries. Samples of water on a test strip that could be sent somewhere for diagnostics. That'd be excellent.
Okay, Edgar, you have the final word.
Well, when we talk about surgical care, I think we have to focus totally. That includes preoperative evaluation, the actual procedure, and the postoperative follow-up. I don't see anything in the operations that can really change things because I see every improvement being every time more expensive. But in preoperative evaluation and postoperative follow-up, I think what I call the cell phone technology is going to revolutionize everything. As I said during my lecture, with a simple cell phone, you are going to be able to receive lots of data from your patients, including EKGs, blood chemistry, and who knows who else will be, maybe image also in the near future. So I think that cell phone technology is going to revolutionize medicine.
Great. Please join me in thanking our panelists for this session.